7, CMS, IM 7. Where is my pen?
Okay.
40, 42 men who is HIV positive comes to, where am I? HIV, something is happening and I cannot think. Okay, HIV positive comes to physician for immunizations prior to trip to Mexico. He's leaving 6 weeks during autumn. He plans to engage in um, typical tourist activity in the metropolitan area. He takes highly active antiretroviral therapy. 3 years ago, he had pneumococcal pneumonia and received the pneumococcal polysaccharide 23 at that time. He received a tetanus booster 5 years ago. Sorry, tetanus booster 5 years ago, and the hepatitis A B vaccines 2 years ago. He had all appropriate childhood vaccination, vital signs normal, examptions non normality, CD4 counts 643, and an undetectable HIV. Which of the following vaccination is most appropriate?
Um, trip to the Mexico.
Mm-hmm, 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 mm-hmm. I cannot
He
write.
he's living 6 weeks during autumn.
Let me do this again. So I am, and then 7. Is it letting me write now? No, it's not letting me write.
You can use pen.
Let's see if that pen work. Nope, it's happening. Okay, I guess I'll use this one. That's the only one that works.
Okay.
Okay, ready?
Yes. So influenza is a
Yours
inf
don't work.
sorry.
Oh, I thought your your mouse wasn't working too. Sorry. Go ahead.
No. I can highlight. I
Oh,
can't highlight too because this is the screenshot. That's why this is not the.
oh, that's why it's not letting. Okay.
Yes. The previous one was the like written document. That's why we can highlight those.
Mm.
Okay. Influenza is a respiratory virus illness that can be complicated by lower respiratory tract infection and bacterial superinfection, especially in elderly or immunocompromised patients. Symptoms include fever, chills, cough, myalgia, malaise, headache, nausea, and vomiting. The CDC recommends annual influenza virus vaccination for all patients greater than 6 months of age. The influenza vaccine is available in trivalent or quadrivalent intramuscular injection of inactivated virus or as a nasal spray of live attenuated virus. Vaccine. Inactivated influenza virus vaccine can be safely administered by intramuscular injection to patients with HIV who may be higher risk for severe illness. Influenza related complication. Influenza is a seasonal illness, typically affecting patients from the late fall and early spring. Okay.
So autumn is like fall.
Autumn.
Autumn.
Yes.
Fall. 92. This sucks. I don't like that no highlighting. Woman is brought to the ED 30 minutes after she was found confused at home. It's not working. 30 minutes where the weather has been extremely hot and temperature in her room was like 97 Fahrenheit. She has multiple infarct vascular dementia and had an MI 30 years ago. Stuporous. She's stuporous. Temperature is high, pulse is high, regular respiration fine, blood pressure low. Exam shows dry mucous membrane, no jugular venous distension, lungs are clear. 2 out of 6 systolic murmur heard at the lower left sternal border. A reminder of the exam is fine. Test for stool or cold blood is negative. Which of the following age-related changes is the most likely explanation for the diagnosis? Which of the following age-related changes is the most likely explanation for the findings in this patient?
Changes is the most likely related changes is the most likely explanation.
No salt wasting.
He's confused in her room. So what's his main problem? Confusion.
It, it confused in her room. Hmm.
What is his primary problem? Then we need to find out on the basis of that. Oh, and then let's see. Okay,
Ready? Ready? Sorry.
yes,
Hmm. It's
you're
the
right.
dementia. It's the dementia part, I guess.
Okay, okay, heat stroke. Heat stroke is characterized by increased body temperature that occurs when the body is exposed to high environmental temperature, high humidity, excessive heat exposure, and increased core temperature lead to cardiovascular and neurologic dysfunction, secondary tachycardia, tachypnea, hypotension, vasodilation of the superficial vessels may lead to multi-organ failure, including hepatic and the renal ischemia, rhabdomyolysis, disseminated intravascular coagulation. Treatment includes cooling of the patient with fans and or ice water, continuous core temperature monitoring, and support of ERS breathing circulation. Heat stroke generally requires neurologic symptoms to be diagnosed, whereas heat exhaustion presents similarly but normal neurologic examination. Heat stroke commonly occurs in young athletes or in elderly patients with impaired thermoregulatory capacity, as evidenced by impaired thirst, blood vessel dilatation, reduced ability to sweat, all reducing the ability to dissipate heat.
You read B.
Yes, normal baroreflex activation changes to the heart rate in response to blood pressure. Normally decreased blood pressure mm, Normally decreased blood pressure would lead to an increase in heart rate to restore mean arterial pressure. In the setting of an age-related decrease in the baroreceptor sensitivity, heart rate does not increase as expected in response to decreased blood pressure, which can cause syncope, lightheadedness, altered mental status. This patient is tachycardic, making this scenario less likely.
Next. 32 women brought to the ED because fever, confusion for 4 hours. She has 5 year history of SLE, lupus. She had Neisseria meningitis 3 years ago. Current medication hydrochloroquine. Temperature is high, and exam shows nuclear rigidity. Kernick site is present. Cerebrospinal CSF shows cloudiness. Gram stain shows gram negative diplococci. Which of the following mechanism is the most likely cause of these findings?
count temperatures, trips, service,
Ready?
okay, yes, it is terminal complement deficiency. Terminal complementary infection, early complement. Okay,
Hello? You
yes,
still there? Oh,
deficiency of terminal complements. Deficiency of terminal components of complement is most likely cause of this patient's recent or recurrent infection with Neisseria meningitis in the presence of fever, nuchal rigidity. The presence of fever, nuchal rigidity, and the CSF fluid analysis demonstrating gram-negative diplopocci is diagnostic for bacterial meningitis. Deficiency of terminal complement factors C5 to C9 impairs the formation of the MAC and predisposed to infection with Neisseria species, although infections tend to occur uncommon serotype. While the common cascade can be activated via classical lectin or alternative pathway converges on the point whereby C3 is cleaved to release C3A and C3B. The C3 convertase complex subsequently leads to activation of the C5 with formation of C5A and C5B. The latter, which complexes C6, 7, 8, 9 to form the MAC. The MAC creates the transmembrane pore that interferes with the integrity of the cellular membrane, leading to cell lysis. Screening of the terminal complement deficiency usually start with the determination of CH50, a diagnostic test that measures the ability of patient's serum to lyse sheep erythrocyte coated with antibodies directed against erythrocyte membrane protein. Because of this measure, because of these measures activity of factor C1 to C9, a deficiency at any point will lead to abnormal result, although in patients with terminal complement deficiency, the CH50 concentration will be very decreased or even zero. In addition to treating infection, further treatment should include vaccination against Neisseria meningitis, Haemophilus influenzae, and Streptococcus pneumoniae. Okay.
okay. Previously healthy 25 men comes to physician 10-day history of fever, sore throat, and generalized fatigue. He takes no medication, became sexually active with new female partner 6 weeks ago, and no condoms. He does not use IV drugs.
Mm.
Temperature is high, pulse is normal, respiration normal, BP normal. Numerous red macules over the upper chest. Exam shows multiple less than 1 centimeter cervical, occipital, and axillary lymph nodes. Less than 1 centimeter. Okay. There is 1 centimeter tender oral ulcer with no exudates of thrush. Throat is injected. Remainder of the exam is fine. Monospot and rapid strep tests are negative. Most appropriate next step in management. Fever, sore throat, and fatigue.
Numerous
Yes, multiple
Is it a
ulcer.
CMB or EVB type of thing?
CMV. Why? The throat is injected. Maybe.
Is there
Choo-choo.
any hepatomegaly? No.
Sickle azithromycin. What's azithromycin for? I don't know. My
Practice.
guess is injected. Okay. Okay. Ready?
The throat is injected. 10-day fever, sore throat. Wait, 1 second. Uh, uh, okay.
I feel like it's a psychovid. I don't know why. Anyway. Nope. I was right.
Okay. Measurement of HIV viral load is the most appropriate next step in the management of high risk sexual behavior and with signs and symptoms of acute retroviral syndrome. The presentation of primary HIV the presentation of primary HIV infection can vary significantly. The presentation of primary HIV infection can vary significantly, and some may experience only a mild febrile illness, while others experience a severe mononucleosis-like syndrome. The time between the infection and the onset of the symptom is variable, with incubation time lasting several weeks or more. During acute infection, there is high degree of viral replication, followed by widespread infection of CD4 T lymphocyte. While the T lymphocyte count may drop transiently, it is often normal in the early HIV. It is often normal in the early HIV unless patients present with signs of opportunistic infection. Initial initial evaluation of the initial lab evaluation includes the use of fourth generation HIV test, which uh, which tests for HIV P24 antigen and antibodies combined with direct measurement of HIV and viral load using reverse transcriptase polymerase chain reaction. It is common in early infection for patients to have negative fourth generation test but have a viral load that is known as window period. Once the diagnosis is made, labs should send mutational analysis and genotyping, but this should not delay the immediate institution of the treatment with antiretroviral therapy. Therapy typically includes a combination at least three different drug from at least two different antiretroviral classes. Okay.
You with E.
Yes, azithromycin therapy is often in conjunction with penicillin or cephalosporin antibiotic is indicated for the treatment of community-acquired pneumonia, which is diagnosed in patients with fever, cough, and infiltrate on chest X-ray. This patient has symptoms that are not easily explained by bacterial pneumonia. Azithromycin is also used in the management of STD.
Asymptomatic 67 man comes for routine exam. His last visit was 2 years ago. He has been healthy since then. Temperature is fine, pulse fine, respiration fine, BP is actually high. Exam shows mild splenomegaly, hematocrit, I believe
Leukocyte count is high.
is high. Segmented neutrophil, I don't know, but bands are high.
Platelet count is
Eosinophil,
okay.
there's metamylocyte, myelocyte, Bailey count is high. Okay, all of that. The diagnosis.
CL,
Uh, plasma cell myeloma, reactive leukocytosis,
Myelomonocytes, myelomonocyte,
CLL,
myelomonocytic.
myelomonocytes. What is monocytes? We didn't even
Mile,
give
mile.
monocytes. Nobody anyway. We didn't even give monocytes here, so it's definitely not that.
Okay,
Let's just CL and CLL. Uh, I don't even know how to. Okay. Five.
okay. This is CML. Chronic myelogenous leukemia is the most likely diagnosis in the asymptomatic male with splenomegaly thrombocytosis, and leukocyte count with the WBC differential demonstrating cells of different lineage. CML is diagnosed by presence of Philadelphia chromosome. Philadelphia chromosome, a translocation between the chromosome 9 and 22, which causes constitutive activation of the ABL kinase protein. Activation of the ABL kinase leads to subsequent activation of JAK-STAT and RAS-MAP kinase (ERK) pathways, leading to increased hematopoietic proliferation, inhibition of normal checkpoint inhibition, and resistance to apoptosis. Typical lab findings in CML include leukocytosis with an increase in nearly all cell lines. Basophilia and eosinophilia are particularly characteristic. Splenomegaly, which at times can be massive, is common. Leukostasis, a condition in which leukocytes leads to end organ damage from occlusion of the capillaries by the malignant cell, is uncommon in CML. This contrasts with conditions such as acute leukemia, in which circulating blasts which are not particularly pliable easily lodge in the capillaries and capillary pulmonary and causing pulmonary and neurologic complication. Treatment of CML is tyrosine kinase. Treatment of CML is with tyrosine kinase inhibitors such as imatinib and dasatinib. Such medications are effective and often result in complete molecular response remissions within several months of initiation. Okay,
Uric A, C, and E.
yes. Chronic chronic lymphocytic leukemia is a malignancy of the mature differentiated B lymphocyte. Common findings include lymphocytosis with peripheral smear showing lymphocytes with large blue nuclei and scant cytoplasm, many of which appear ruptured, known as smudge cell. Treatment with ibrutinib is initiated if patient has profound cytopenia or disabling symptoms such as malaise and a bulky lymphadenopathy. Chronic myelogenous leukemia is a myeloproliferative neoplasm of the monocytes and presents with increased monocyte count. Myelocytes and monocytes are both derived from undifferentiated multipotent cells, but they are distinctly different cell lines. These patients' peripheral blood smear does not show an increased circulating concentration of monocytes. Okay.
And E.
Reactive leukocytosis is often seen in reactive leukocytosis is often seen in response to infection, trauma, or acute stressor such as acute coronary syndrome. In patients with this condition, peripheral blood smear discloses leukocytosis with neutrophilia often exceeding 80% of the total cell count, and in this case severe infection may show an increased percentage of immature neutrophil. These patients' differential and asymptomatic presentation are not consistent with reactive leukocytes. Okay,
Next, 47 woman, 5-year history of rheumatoid arthritis, comes to physician for follow-up. She has morning stiffness in her hand, but otherwise she has morning stiffness but feels well. Medication, prednisone, and methotrexate. Vital signs normal. Exam shows mass swelling of the metacarpal and proximal joints. The remainder of the exam is fine. Hematocrit is actually low. MCV low. ESR, I believe is normal. Total iron binding capacity is low. Ferritin, I need
ferritin
to
isn't
check.
it high?
I'm thinking, let me see. ESR is actually high. Ferritin, where are my notes? Ferritin is high. And then iron is, what is
Low.
she? Is low.
I think that iron is locked up in the macrophage due to rheumatoid arthritis. Is it ACD?
Which, oh, let me see what they're asking. Most appropriate next step in management of this patient anemia.
What is your diagnosis?
Mm, the inflammation one. But then this one doesn't. Transfusion of packed red blood cells. No. Oh, what is happening? Should we do the bone marrow biopsy? That makes sense. Okay, ready?
Yes. Okay, you are right. No further evaluation or treatment is indicated at this time for this patient with RA, microcytic anemia, iron studies disclosing increased ferritin concentration. Patients with microcytic anemia should be evaluated for iron deficiency through measurement of the total serum iron concentration, ferritin, and the total iron binding capacity. Iron deficiency anemia manifests as decreased serum concentration and increased TIBC and decreased ferritin. Calculation of the transferrin saturation is also useful. This is calculated by dividing the serum iron by the dividing the serum iron by the iron binding capacity, then multiplying by 100. Numbers less than 20% indicate iron deficiency anemia, while numbers 20 to 50% are considered as normal. This patient has increased ferritin concentration and transferrin saturation 20%, both of which are most consistent with anemia of chronic disease. Anemia of chronic disease in patients with autoimmune or inflammatory or infectious or malignant condition, the pathophysiology may relate to upregulated hepcidin, resulting in intestinal absorption of iron and reduced release of iron from macrophages. While patients may not be iron deficient, their iron stores are unavailable for hematopoiesis, leading to anemia. Treatment focuses on the underlying condition, which in this case is rheumatoid arthritis.
Okay. Next, prior to discharge to a skilled nursing facility, 80 woman is evaluated in the hospital because of decreased hemoglobin concentration. She underwent a mycolectomy 10 days ago for GI bleeding, secondary to diverticulosis. 4 units of packed red blood cells were given during the procedure. She has hypertension, diabetes, medication is inappropriate, metformin, temperature fine, pulse fine, respiration fine, BP fine, physical exam shows mucosal pallor and conjunctival icterus. Abdominal exam, well healing incision, baseline hemoglobin concentration on postoperative day 3 is 10, so low. Hemoglobin concentration today is 5, so you got an even lower. Labs are most likely to show which of the following additional findings. What is
After
causing
10 days.
bilirubin concentration? What is causing her to bleed?
Is it ITP?
Why?
There is no reason of this rapid low hemoglobin.
Conjunctiva, icterus,
Is there
postoperative.
anything you have found why there is such low hemoglobin? I think Coops is positive and indirect is high.
Direct increase, indirect.
What is your diagnosis?
There is no, I don't have a diagnosis in this. Um,
Why hemoglobin is low? Why hemoglobin is rapidly fall down?
um, uh, bleed, hemicodectomy.
And
Uh,
there is no bleeding, isn't it?
says no.
So somebody is breaking the hemoglobin.
Okay.
And
Okay,
if hemoglobin is broken down, then indirect bilirubin would be high.
oh, sorry, what am I doing? Ah, hemoglobin. Ready?
You are using Apple.
I'm like, I don't even know how to mark it anymore. Whatever. It's okay.
Okay.
Ready? Seven. Oh, I was completely wrong. Maybe you were right. It was, let me see. Nope.
No, it is
Oh,
hemolytic transfusion
you
reaction. But
see, when I don't highlight, like, I don't know what's important. The transfusion was right there.
yes,
But
right
this
there.
one,
I was seeing at the transfusion. Okay. This block will make you suffer as because you are unable to highlight. Okay. Lab studies are most like lab studies are most likely diagnosis. Labs lab studies are most likely disclosed a positive direct antiglobulin Coombs test uh, and an increased serum concentration of indirect bilirubin, which is consistent with hemolytic transfusion reaction. This patient's presentation 10 days following blood transfusion and not immediately during transfusion suggests delayed hemolytic transfusion reaction. In contrast, acute hemolytic transfusion reaction arises. In contrast, acute hemolytic transfusion reaction, which arise because of ABO incompatibility, can be life-threatening. Delayed hemolytic transfusion reaction results from the presence of autoantibodies against the minor erythrocyte antigens Rh antigen. In all cases, delayed hemolytic transfusion reaction requires prior exposure to the antigen for the patient to produce antibodies. But in some instances, the antibodies may not be found in titers during the routine blood bank screening to be appropriately recognized. So the Coombs test involves incubating the patient's erythrocyte with anti-IgG and anti complement antibody known as Coombs reagent. If an autoantibody or complement is bound to the surface of the erythrocyte, the Coombs reagent will bind to it and cause agglutination, resulting in a positive test. The fixation of the fixation of complement results in intravascular hemolysis and increase in direct bilirubin, which, while binding of the antibodies to the surface of the erythrocyte, may mark them for removal in the reticuloendothelial system. In either case, patients presents with anemia and evidence of hemolysis. Treatment is supportive.
Next, 52 men brought to the ED 1 hour after a 30 minutes episode of weakness, right arm and leg, and difficulty speaking. Symptoms result spontaneous. His last visit to the physician was 35 years ago. Pulse is fine, BP high, cardiac exam shows a diffuse point of maximal impulse, and S4 gallop. Left femoral brake is hurt, left femoral. Neurologic exam shows no focal findings, labs, hemoglobin low, glucose gets high, creatinine high, cholesterol I'm guessing is high too. ECG shows left ventricular hypertrophy. Let me double check cholesterol. It's actually normal. Oh, it's actually normal. Treatment of each of the following is most likely to have prevented these findings. Oh, treatment. Okay.
The, your theory, like a stroke for hypertension,
Oh, is that
and
what you? I mean,
like there is two factor in here, like hypertension. Actually, uncontrolled hypertension cause LVH, left ventricular hypertrophy. One thing, and another is 30 minutes. There is a TIA,
hmm
so both goes with the hypertension, isn't it?
yeah, yeah, you can look at it like that. Yes, I think so.
Okay.
Yeah.
These questions are very confusing. That's why I am asking.
No, but the way you thought about it was good.
Okay. Okay. These patients present symptoms of transient weakness and dysarthria or aphasia are consistent with TIA, defined as a transient episodes of neurologic dysfunction caused by focal brain, spinal cord, retinal ischemia without evidence of infarction. Additionally, the patient presents with signs of congestive heart failure, peripheral vascular disease, and CKD, enlarged, including an enlarged point of maximal impulse, an S4 gallop, and a femoral bruit, and increased creatinine, respectively. This patient has multiple risk factors for TIA and ischemic stroke, including hypertension, diabetes mellitus, dyslipidemia, atherosclerotic disease. Is the single most hypertension is the single important modifiable risk factor for TIS and ischemic stroke, and is an important contributor of the congestive heart failure, CKD, and PVD. Okay.
Otherwise healthy, sorry, 92 women brought to the physician by her family because 1 year history of cognitive decline. Her daughter reports that the patient seems to fish for words and often repeats questions. Patient 94-year-old husband had not noticed a problem. He has not. 20 years ago, she sustained a concussion after falling off a horse. She is a high school graduate. Her 90-year-old sister has significant memory problems. Two younger brothers have no memory problems. The patient takes no medication. On exam, she's pleasant, cooperative. She knows the year but not the month and date. She can recall a recent holiday. She has no difficulty naming object by sight. But when asked to name as many animals as she can in 1 minute, she can only name five. She recalls one of three items after 5 minutes. Which of the following is the strongest predisposing factor for this patient condition? What condition she got?
Is is it age 92 years old?
I think so. I mean,
Is there
she's really
anything
old.
like, yes, he is very old and it is very normal that he is unable to remember.
Yeah. Okay.
Looks like.
Let's double check. Yes, you're right.
Okay. So it's a age. Alzheimer's disease is the most common type of dementia. It typically presents with progressive cognitive deterioration that begins with a short-term memory impairment and a decline in the visuospatial abilities, which progress to apraxia, language abnormality, dysexecutive syndrome. The disease culminates in behavioral and personality changes that prevent the patient from performing basic activities of the daily living, such as bathing. Age is the strongest risk factor of the AD. The incidence of the ADA approximately doubles every 5 years after age 65. Less significant risk factors include hypertension, hyperlipidemia, diabetes, and a sedentary lifestyle. AD may be treated with drugs and that both directly and indirectly increase the acetylcholine in the synaptic cleft. These includes donepezil, a cholinesterase inhibitor, non-competitively reverse, which non-competitively and reversibly inhibit anticholinesterase and thereby increasing the amount of the synaptic acetylcholine available for neurotransmission. Though these drugs may slow the rate of the cognitive decline and modestly improve functionality, they are not curative of Alzheimer's disease.
Okay. Next. Previously healthy 42 men comes to office because of severe right-side headache for the past 3 weeks. He says that he awakens every night at 3 a.m. with a sharp stabbing pain behind the right eye that usually lasts for 30 minutes. There is no associated nausea. He has smoked for 25 years, drinks a lot. Vital signs normal. Exam during an episode shows ptosis of the right and tearing and conjunctival injection. The right pupil is 2 millimeters and the left is 4. I guess it's small. Diagnosis.
Is it cluster headache?
Mm, 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 yes. Yep.
Okay, cluster headaches are primary headache that typically presents with brief, less than 120 minute, unilateral severe pain in the orbital, supraorbital, or temporal region of the head and are accompanied by ipsilateral autonomic symptoms. The pathogenesis is incompletely understood. The pathogenesis is incompletely understood, but likely involves activation of sensory fibers of the trigeminal nerves and parasympathetic nerves. Autonomic symptoms commonly include ptosis, miosis, lacrimation, conjunctival injection, rhinorrhea, and or nasal congestion. Patient typically presents between the ages 20 and 50 years and are often male. Cigarette and alcohol use may be triggers For patients with a history of cluster headache, the headache often recur uh, over a series of weeks to months, and sometimes at the same time each year. Oxygen therapy with 100% oxygen is the most effective first-line abortive treatment, and verapamil is the first-line prophylactic management. The clinician should always distinguish primary headache, tension cluster migraine from secondary headache types, intracranial bleeding, tumor, glaucoma, because the treatment and prognosis differ greatly. Okay,
Okay. I want to stop here.
okay,
Okay. I will see you tomorrow.
okay. You can answer this. It is
I'm not.
stuck on appearance.
Which of the following historical factors most likely increase this patient risk for developing this?
What is the historical factor? Dark. Isn't it seborrheic keratosis the stuck on appearance?
Yeah, but what what is the historical factor that increase this?
Okay,
Medical
you are very good in this answer. I will follow your
history.
answer.
No, I have to read this. This doesn't make sense to me. I have to read the whole thing. Just
Okay,
the picture
yes,
tells it.
okay. Read. It is the last question. Okay.
Okay. Comes to the 58 man comes to office because 1 year history of enlarging painless non-itchy lesion in the inner thigh, right inner thigh. Notices the lesion only when he bathes and believes he might be developing a similar one on the right forearm. He has HIV, which is controlled by medication. He only takes a daily multivitamin, no smoking or alcohol. He used heroin for 5 years but stopped. He has worked on a farm for 40 years. Vital signs are normal. Photograph of, yeah, right here. Exam of the right forearm raised lesion with well demarcated borders and dark pigmentation. Ah, the remainder of the exam is fine. Which of the following historical factors most likely increase the patient risk of developing this? Hmm.
Is it HIV? What
Is
is?
HIV? Okay. Is
But
HIV
is HIV is historical factor?
history? I'm thinking, yeah.
Okay.
No, or the
I,
occupation.
I will
Occupation
follow
don't.
you because I don't know.
Or is it the age? Because if it, no, it doesn't make
Why
sense.
age? I'm thinking. Is there anything relation to age? In
No, no. Usually it's like cancer. What that it's medical history. I think 11.
our
Oh my lord, it was age. Ugh, I knew I should have just stopped there.
oh
Oh my
no,
god,
this is this type of shock we need. Like I need.
Jesus.
So
Ugh, okay,
seborrheic
read it.
seborrheic keratosis is a benign proliferation of the epidermis. It is characterized by histologically a benign acanthotic proliferation of the keratinocyte with absence of cellular atypia. The lesions are typically round, raised, brown, or tan in color, and are sharply demarcated with an adherent or stuck-on appearance. Seborrheic keratosis is common in middle-aged or older adults and is most associated with increased age, while seborrheic keratosis is benign. The sudden appearance of numeric seborrheic keratosis lesions on the backs and the trunks, known as known as lizard fillet sign, can be a paraneoplastic manifestation or GI malignancy. No treatment is necessary for seborrheic keratosis, although lesions are cosmetically bothersome and may be removed with cryotherapy or simple excision. Okay,
Okay, I will see you tomorrow.
okay, bye bye.
Bye.